Hello, listeners. I'm very excited about this episode that we are going to do all about these anti-obesity medications. And boy, oh boy, I just read that one half of US adults that were recently surveyed said that they would like to take these drugs. And 93 million Americans generally meet the accepted medical criteria to take them. In fact, what I read was that as many as 25,000 people are starting these new weight loss drugs every week. So today, what I brought on is an expert in this field because we want to see, are there potentially any negative side effects from taking these drugs? So stay tuned. Okay, we're back with my special guest. Once again, I always go right to the top. This Dr. Carolyn Apovian, MD. She is a professor of medicine at Harvard Medical School and also the co-director of the Center for Weight Management and Wellness in the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital here in Boston. And she is a New York Times bestseller. She's published over 10 books and she's, peer reviewed, published over 200 articles. And I want to tell you something. This is why we're doing this episode, because she wrote this phenomenal paper in clinical trials and investigations. And I'm going to put a link to this on the Spot On Facebook page. But she wrote about all the nutritional concerns when you're on these anti-obesity medications. So, Dr. Apovian, I want to thank you so much for coming on Spot On.
Joan, it's a pleasure to be here and talking to you today about my favorite subject, nutrition.
I know you're like the doctor guru in this subject. And Dr. Povian, we've done a segment on anti-obesity medications, but can you just refresh our memories a little bit? Can you explain how these medications work and how they help individuals, lose weight?
With obesity, yes.
Yeah.
So we know that obesity is a disease, and these medications are analogs of naturally occurring hormones that are secreted in the gut after you eat. And what they do, these secretions, these hormones go to the brain and tell the body that you're full. Okay. They also do other things. That's why they're also approved for diabetes. They increase insulin secretion. They delay gastric emptying. The main piece is the appetite suppression, and because you're giving an analog of a naturally occurring hormone, you are adding more satiety hormone to the mix, and you're allowing the body to defend a lower body weight. And so these are meant to be drugs that you take all the time, forever, because you're going to lose weight. And as long as you're on the medication, you're going to keep the weight off. Now, there's been a big concern about muscle loss, but we know that any kind of weight loss, it's not just fat that you lose, it's also muscle. That's metabolism. When you lose weight, you burn fat, but you also burn muscle because you need amino acids as well. And so in order to counteract that muscle loss, you have to change your lifestyle. And your lifestyle, so you're going to talk about that. You're going to ask me about the lifestyle.
Absolutely. And this is what this article was all about, because, again, that these medications were used for people with diabetes and they worked wonderful, and that's really great. And there is benefit. They can lose some weight, but we have to make sure that they're doing it in a way that is helpful and not just taking the pill, and also looking at their diet and lifestyle. Today I was reading about Dr. Apovian that there's now maybe a new generation of oral pills. These ones that we used in the past were injected, right? But now they have oral?
No, so not quite. These injectable agents there's semaglutide and tirzepatide. We are using them now. It is not in the past. We've only had them for a few years. We do have a 5-year outcomes trial called the SELECT trial that has shown that if you're on semaglutide for 5 years and you had obesity and a heart disease risk, you reduce your chances of another event like an MI, a heart attack, a stroke by 20%.
Wow.
So these are not going away, and they're not in the past. I don't think the oral agents are in research right now, but I don't really think they're going to be as good and have as, good a side effect profile as our injectable agents. And, I mean, these injectable agents it's like an EpiPen.
Right. I get it.
It's very easy to use. It's once a week.
Mm-hmm.
People don't have a problem at all.
Right. How much weight can you expect a person can expect to lose when on this medication?
Semaglutide in the trials, at a year, the intervention group lost an average of 16.7% of their body weight. And with tirzepatide, patients lost an average of 20.9% of their body weight. So, if you weigh 250 pounds, you could lose 40 to 50 pounds. You gotta, if you stop the medication, of course, you're going to gain it back. That's right. The point. The point is that you're going to reduce the body weight that your body wants to be at in this environment.
Right, right. In this article, this fabulous article, and again, we're going to put this on the Spot On Facebook page, you shared some potential negative side effects of taking these medications. One of them was GI issues. So what could happen in the GI that could have a negative issue?
Okay, so we need to understand what these medications are. So they're analogs of naturally occurring hormones. So let's talk about what are these hormones? They're GLP-1. GLP-1, GIP, glucagon, PYY, oxantimodulin, and currently the 2 injectables that we have are GLP-1 or semaglutide and GLP-1 GIP or tirzepatide. Now, what happens in the body when you eat? Well, GLP-1 is secreted. When you eat too much, you may get nauseous. When you eat, you're going to feel full. And if you eat too much, you're going to get nauseous. And if you really eat too much, you're going to vomit. Oh, wow. Those are the side effects of these incretin hormones. They're naturally occurring agents, and they're just going to simulate. So what happens is that in some people, you give them a GLP-1 and they react. They have a super reaction. It's a super reaction. Not only do they feel full, but they get nauseous. Mm-hmm. That it may be that for them it's too much. And but what these studies have shown is that if you dose it slowly, so you may know that semaglutide comes in 0.25 injections, 0.5, and you go up slowly till you hit 2.4. Well, the reason why they're dosed slowly is because if you dosed right away to 2.5, you would really have nausea, vomiting, and never want to take an injection again. So
right. Well, Dr. Pope, it sounds like it might be self-correcting. So if you eat too much and you feel full, then you might say, okay, next time I'm not going to eat as much. And will that suppress that feeling of feeling nauseous?
No, it does. No. That's not how this medication works. Okay. Originally, when the first studies came out for gut incretin hormones, the thought was, well, you're just losing weight because you're nauseous. But the scientists studying this convinced clinicians pretty quickly that it's not from the nausea that you lose weight, because the nausea it goes away pretty quickly. It's mild to moderate, and then after a while, there is no nausea for most patients. So, and for semaglutide, again, the side effects go away in a few weeks, and you can increase the dose without much nausea. And then, the point is you're on this drug forever. So you certainly don't want to be nauseous forever. So that wouldn't work.
Right.
But they did, in studying these gut hormones, they realized that you are, the activity of the GLP-1 in the gut and in the brain causes satiety and a satisfaction with your weight at a lower body weight. So that leptin was discovered as the first hormone in 1994 that governed your weight. And when you lose weight without any medication, leptin levels really change and go down. And when leptin levels go down, your body thinks it's starving. Okay, so
because leptin helps with making you feel full.
It does.
Okay, right.
It's secreted from fat. If you have less fat from weight loss, less leptin is secreted. When less leptin is secreted, there is unopposed hyperphagia, because there's nothing to dampen that hyperphagia in the brain, and so you start eating.
Right. So the hyperphagia is overeating. So there you go. Wow. So again, we got hormones affecting hormones, and it's interesting. When you're losing weight, there are things, as you said, that are going on. You said something in this article, a fabulous article, that some individuals may get malnourished, or there's a risk for that, to do that. And can you talk a little bit about that?
Well, it's rare, Joan, but it's possible that people who are taking therapy, like a gut hormone therapy for obesity, if the satiety is pronounced, you may not feel like eating, and so you don't eat. And if you're not on a healthy diet,
right,
you could possibly theoretically develop malnutrition, but that's really pretty rare. I don't think we've seen it yet, because the reality is, Joan, that the body has an incredible pathway that prevents starvation. So there are multiple ways that the body reacts to loss of food intake. Again, you lose weight, leptin levels drop, there's unopposed hyperphagia, you get really, really hungry, ghrelin levels go up, and there is really, no way that you can prevent eating unless, you have anorexia or some kind of cardiac cachexia or some, aversion to food. But most people in this environment are not going to, die of starvation unless they have no money to buy food. So it's very, very difficult to develop malnutrition from, taking a gut hormone therapy.
Right. But I guess depending on, like what you said, if it was an unhealthy diet to begin with, and then they're taking it, one needs to make sure that they're eating healthy while they're taking the drug. And you talked about in this article about the role of registered dietitian nutritionist which you know I am, and I know you work with them all the time to help people, when they're on these medications to improve their diet and improve it. So, you talked about in the article here that they got to make sure they're getting enough fiber. And why is that?
Well, it's not just if you're on a diet, a healthy diet. As you know, healthy diet, you've got to take in at least 25 grams of fiber for your colon health, so that you don't have a risk of developing colon cancer or breast cancer. But some of these medications have, as I said, the side effects could be nausea, vomiting, constipation, diarrhea. Now, the constipation is due to the fact that these gut hormones delay gastric emptying. They have multiple mechanisms in the tissues in the body, and at the gut level, they delay gastric emptying. So you feel full for longer, but if you really delay gastric emptying, you can get constipated. So in the beginning, before we really knew how to counsel to prevent these side effects, we did see patients go to the emergency room with small bowel obstruction from days and days of constipation. And so now we counsel all our patients who are going to start semaglutide or tirzepatide that you really want to make sure that if you get constipated, that you do something right away, which is whatever way increase your fiber intake. If you get constipated, you really need to do something probably more quickly. So Miralax and Colace, Senna, if it really gets bad, but you got to do something. And that usually means adding fiber and a stool softener. So those are one of the side effects that you want to keep abreast of so that you don't get constipated. But in general, a healthy diet means a diet that's high in fiber, high in protein, and high in fruits and vegetables and whole grains, and good fats. So whatever diet it is, a Mediterranean diet, as long as it has those constituents, you're going to do well on these medications. The issue about muscle loss is very important because any kind of weight loss is going to cause not just fat loss, but muscle loss. And the only way to mitigate that, any diet and exercise program, bariatric surgery, any of these medications, is to eat a high protein diet and do resistance exercise training. And so I would think the number one major worry that we have, especially in older people on these medications, is loss of a lot of muscle mass and development of functional abnormalities like falls and osteopenia, fractures and muscle loss. And that is the one thing that long term we do worry about, especially in the older population, because they already have sarcopenia and obesity.
Right. So again, any kind of weight loss, it's very important to have enough protein in the diet. Should people be, especially on these medications or even when they're losing weight, spreading out their protein during the day? Does that matter, or just getting adequate amount of protein?
Well, that's a good point, Joan. Studies have shown that in the older population, you're going to improve your anabolic potential by spreading out the protein. So the RDA for protein, as you know, is 0.8 grams per kilogram per day. So in general, that starts about, 60 grams of protein, 80 grams of protein. But in the case of older people, older than 60, 65, there is a lot of literature that suggests that older people need more protein, up to 1.2 to 1.5 grams of protein per day.
That's almost double at the higher end. Yeah, wow.
That's almost double. And on top of that, when you're losing weight and you're older, you probably really need to make sure you're doing that, because after the age of 40, you lose about 1% of your muscle mass per year.
Right.
And so by the time most people are 50 to 60, they already have sarcopenia, which is the muscle loss of aging. And when you have obesity and you're older and you're losing weight, you're going to lose muscle if you don't eat a high protein diet. And so I think in the end, the real risk that we run is sarcopenia and functional difficulties. That's really the long-term issue that we're struggling with now in the obesity field, is what to do with muscle mass loss. How do we mitigate it? And there are many pharma companies that are studying how to use things like myostatin antagonists to protect muscle and keep the muscle there and keep it from being broken down.
Oh, so interesting. Yes.
Yeah, that's way in the future.
That's great. That's really interesting. And, it's important that what you said, a healthy diet is going to give you those vitamins and minerals you need. You said something in the article about fluid, and that these medications may cause dehydration, or can you explain that? Or?
Well, it's not from the medication per se. Again, any kind of weight loss can cause dehydration. So let's think about why that might be. When you lose weight, you reduce your calorie intake, mainly from, you should be reducing your calorie intake mainly from ultra processed foods, and which are mainly carbohydrates mixed with fat, but carbohydrates. When you reduce your calorie intake and mainly carbohydrates, you reduce insulin secretion from the pancreas. You don't need as much insulin. So insulin is an anti-natriuretic hormone, which means that it holds on to water and salt in the body, anti-natriuretic. So when you have less insulin coming out because you're on a diet, you're going to lose a lot of water suddenly. And that many people think that, I lost 10 pounds the first week on this diet. Well, it's not fat, it's water. So if you keep doing that, you're going to get dehydrated. So any kind of weight loss is going to do that. It's not the GLP-1s necessarily. We call them GLP-1s, but they're really gut hormone therapies. So it's very important to make sure that you're drinking enough water per day. And it's also important that what you should also be doing besides the diet is exercise. And so you've got to replenish the loss of fluids and through sweat that you get from doing exercise. So you want to make sure that you're drinking the water. You also want to make sure that, as you mentioned earlier about when should you take your protein in. Yes, there are many studies that show that older people utilize protein when it's given in periodically during the day. So you don't eat all your protein at dinner. If you eat like 100 grams of protein at dinner, you're not going to absorb all of that, especially if you're older. You should take in protein at each meal. And we did a study showing that when you supplement protein, how do you supplement protein? Usually from a protein drink, mixed powder in a shake or whatever. You should take that, and it's usually 20 grams of protein. You should take that 20 grams of protein in between your meals if you're really trying to boost your protein intake. So several things going on. The type of food, you want to make sure the foods are high in protein and fiber, fruits and vegetables, but also make sure that you're taking in 1.5 grams per kilogram of protein per day and you're drinking enough water.
Dr. Povian, I think these medications are really could be so beneficial for so many people. But it also sounds like, because of all the things you just said, the protein, the fiber, the water, vitamin and minerals you got to be meeting, it sounds like you should be taking them obviously under the direction of a physician such as yourself who specializes in this. But it also sounds like you may get benefit working with a registered dietitian nutritionist who specializes in this area to also help you with making sure your diet is adequate and nutritious, and also maybe looking at changing some things in your diet that maybe could be good for you long term when it comes to keeping weight off. What are you
There's
thinking?
no doubt about it. I all my centers, I've developed 3, 4 centers in my career. I have employed dietitians to help us in our work to treat obesity. We doctors do not have are not taught nutrition in medical school. They're still not taught nutrition in medical school. You got to get a PhD in nutrition if you really want to understand nutrition. Like my colleague has, the MD, PhD in nutrition. Those are the only people really who truly understand nutritional metabolism, not a doctor. And so many doctors are out there who are prescribing, as a primary care physician, prescribing, Wegovy and Zepbound, Ozempic and Mounjaro, but not really providing any healthy eating patterns to help that patient. Needless to say, not even talking about exercise, because they're also not exercise physiologists. So because exercise physiology is an added element, and right now we don't, no one's covering it under insurance. I can't hire exercise physiologists, but I certainly can utilize our registered dietitians, and I do. Every single patient who I see, who my team sees, and we saw 12,000 patients last year for obesity and diabetes. Every single one sees a registered dietitian at least once, if not multiple times, because of the importance of changing your diet when you're trying to lose weight and keep it off by any means. Even patients who undergo metabolic surgery are seen by dietitians. It's very, very important because, again, nobody else is going to talk to you about, what you should be eating at each meal and how to plan your meals and, recipes and what proportion of your plate should be starch, protein versus fat and other items. That is all the purview of the registered dietitian. Very important part of the multidisciplinary team that can treat obesity.
Right. So that's the nutrition expert. And, this article is phenomenal to bring that forward, that's important, that we just can't give the medication. We have to augment it with a team approach here, everybody trying to help, especially the registered dietitian nutritionist, so that we can avoid some of the nutritional deficiencies or whatever occur, or and something that can help, making long-term behavior changes in the person's diet and lifestyle. And, I can't thank you enough. I have to tell you, in transparency to those that are listening and watching, that I've known Dr. Apovi, and she doesn't look that old or anything, but I've known her for 100 years.
Yeah.
And she is correct. And she was one of the very few physicians in this weight management arena that really valued registered dietitian nutritionist. That's why she's so valuable, because she got it. She understands it. She understands the whole team effort. So, I can't thank you enough for being who you are and understanding the role of nutrition, valuing the registered dietitian and nutritionist, and most importantly, writing articles like this to get out to the healthcare physicians, PA, nurse practitioners, and even the public to say, wait, these medications, any weight loss could be helpful, but let's do it the right way. And so I really can't thank you enough for your support of the role of nutrition that plays. And you are, I don't want to say a pioneer because you're not really that old, but you know what I mean?
Well, you're so sweet, Joan. But I've always understood we need more dietitians, not less.
Right.
I,
And
we need more.
you heard that from the guru, okay? So I just want to thank you so much for coming out, and being on Spot On and sharing this expertise because I'm going to tell you, it's going to make people think, and you are just fabulous. Thank you so much.
Joan, thank you for doing what you do and hosting Spot On and really getting this information out to the public. We really need treatment. We really need to utilize preventive health. And it starts with a healthy diet. That's the bottom line. You are what you eat. You really are.
Dr. Povian, you are spot on. What can I say? Thank you
Thank
again.
you, Joan. Thank you, Joan Salge Blake. It's always a pleasure to talk to you.